how does it work? Okay, so today we will be talking about this diabetes mellitus. Okay, now I'm audible to you, isn't it?
Yes, sir.
Yes, sir.
Yes.
So what is diabetes mellitus? Diabetes mellitus, it is a disorder, okay, which is characterized, this is a metabolic disorder, okay, where the metabolism goes wrong, and it is characterized by hyperglycemia. The glucose level in the blood increases, glycosuria, glucose level in urine increases, increases, negative nitrogen balance, and sometimes even ketonemia, which is more common in type 1 diabetes mellitus. And the sign and symptoms of this diabetes mellitus is increased frequency of urination, that is polyuria, and excessive thirst, that is polydipsia, and excessive eating, polyphagia, and fatigue, and unexplained weight loss, etc. Okay, so these are some of the characteristic features. There will be frequent urination. The patient will feel thirsty, drink more water, and there will be excessive eating also. Weight loss, okay, for in short period of time, that is unexplained weight loss. There is eating is more, and then fatigue. So maybe the exercise symptoms, the common symptoms of diabetes mellitus. Okay, and talking about the diabetes mellitus types, it is classified into 4. That is type 1, and previously it was also said to be insulin dependent diabetes mellitus. So IDDM, that means insulin dependent diabetes mellitus. Okay, here the patient is dependent on insulin. The patient has to take insulin. Okay, so that is why it was said insulin dependent diabetes mellitus. Why there is dependency in insulin? Because to absolute deficiency of insulin. The insulin deficiency is there, absolute. There is no production of insulin. So insulin level is less, or there is no insulin, and that insulin which controls the blood glycemia. So that is what. So there is a no production of insulin. Why no production? Because there is the isolate of beta cell of pancreas. The pancreas beta cell are being destroyed, damaged. So that type 2 diabetes mellitus, which also we say non-insulin dependent diabetes mellitus. There is actually insulin is there, but the quality and quantity of the insulin is not sufficient to meet the demand of the body. Body requires the requirement of the body, insulin requirement by the body is more, and there is that demand is not meet. The okay, requirement is more, that requirement is not fulfilled. Okay. So that is what we say the relative insulin deficiency. Okay, the quality and quantity of insulin may not be proper. In that case, it is not necessary always we have to give insulin. We can give some other oral anti-diabetic drug which say increase the sensitivity of insulin, or they may stimulate the beta cell of pancreas, and insulin will be released. Okay, so stimulate the production of insulin by the beta cells. So that is what is type 2. And type 3 is there is increased glucose level. Okay, the glucose is not sufficient, and that has led to increased blood glucose level. Okay, so that is what is type 3. It is generally caused by diseases or sometimes medicines like corticosteroid. You have recently read the corticosteroid. Corticosteroids has opposite action of that of insulin, and insulin is more, which is not being catered by the pancreas. So that is type 3. Okay, and type 4 is this is what we say gestational diabetes mellitus. Okay, there is increased glucose level which is observed for the first time during the pregnancy, found during the pregnancy, then we say it as a gestational diabetes mellitus. So even though there are 4 types, okay, but the most common is the type 1 and type 2. We will be more focusing on type 1 and type 2, even though IDDM means non-insulin dependent diabetes mellitus. These terms now, it is not very commonly used and preferred one. So okay, earlier it was used, but nowadays we prefer to say type 1 and type 2. Type 1 means we have to give insulin, okay, because there is absolute deficiency of insulin, while in type 2 there is the insulin may not be required or may not be necessary. Okay, so that is the type 2. Okay, got it?
Yes, sir.
Any doubt? Diabetes mellitus, its type will also be discussed in physiology, and I think in pathology. Has it been discussed? Even there also it will be discussed. Okay, so again there will be revision. So now I have already said the type 1 and type 2 is more common, and this the comparison will be there in physiology also, pathology also, so there will be revision. Okay, just for the introduction, or you can say it is the portion of diabetes mellitus which is required to know the medicine, or say to discuss pharmacology, whatever things about the diabetes mellitus is required, I will be talking about that. Okay, so type 1 diabetes mellitus and type 2 diabetes mellitus, this is very common. And what is the difference between these is type 30 years. So that is why we say juvenile diabetes mellitus or juvenile onset, while type 2 diabetes mellitus nowadays it occurs generally after 40 we say, but nowadays even after 30 it is now seen. So after 30, so in elderly people it is seen, so it is maturity onset diabetes mellitus. And here in type 1 diabetes mellitus, the beta cell is destroyed. The beta for production of insulin is destroyed, so insulin will not be produced, and insulin is required to control the blood sugar level. Our blood sugar the level could not be maintained and level increases, so that is why there will be hyperglycemia. Insulin by beta cell are destroyed. Okay, and this destruction could be autoimmune or some idiopathic cause. So that is why this type 1 could be divided again into type 1A and type 1B. A means autoimmune. Okay, some antibodies are formed against that those beta cells, and then it has been destroyed, or by some other cause it is destroyed. So we can classify this type 1 into type 1A and B. Insulin could not be produced, and that is why blood glucose has increased in type 1. So in this case, so since there is the absolute deficiency of insulin, we give insulin from outside. We give insulin to the patient from outside. Okay. So while in type 2 diabetes mellitus, what happened? The beta cell are not destroyed. Okay, the beta cell is there, it is producing insulin, but that insulin is not sufficient. Okay, sufficient. Okay, so that is why there is a relative deficiency. Okay, insulin is not sufficient. Okay, so beta cell are there, so that is why in this case in type 2 diabetes mellitus we can use some drugs orally used. Insulin may not be required. Okay, so in that case we use drug, and those drugs may stimulate beta cell to produce more insulin. Okay, so this type 2 diabetes mellitus we can divide into mild deficiency of or very less deficiency of insulin. We say it as a mild diabetes mellitus type 2, or if it is a severe, then we say severe. And generally, this in type 1 diabetes mellitus, the patient is more prone to ketoacidosis. We will discuss about this diabetic ketoacidosis in detail. But in type 2, the diabetic ketoacidosis, they are less prone to diabetic ketoacidosis. This type 1 diabetes mellitus, it is less common, okay, and less genetic predisposition. Okay, genetic cause is less, while in type 2 diabetes mellitus it is very common nowadays. When most of the people, if say they are suffering from diabetes mellitus, that means mostly they are that is type 2 diabetes mellitus, and they are high genetic predisposition. So that is why you like people used to say, my father used to have diabetes, my mother, so there is the high chance that I will get diabetes mellitus. So there is a genetic type 1 diabetes mellitus, the insulin is must. Okay, and while in type 2 diabetes mellitus, it is controlled by dietary change and exercise. And if diet and exercise is not sufficient, then we use oral anti-diabetic drug, okay, to control the increased blood glucose level. And if that oral diabetic drug fails, then we used to combine 2 or 3 oral drugs for diabetes mellitus. And even that fails, the multi-oral the anti-diabetic drug fail, okay, then we have to start insulin. Try to control it with diet change, okay, and exercises. And if that is sufficient, well and good. Otherwise, we will add the drug, and the drug slowly, after some time, even one drug may not be sufficient to control the diabetes mellitus. That time we add some other drug, okay, some oral anti-diabetic drugs. And when that also fails, then we go with insulin. So the treatment aspect we will cover in coming classes in therapy of diabetes mellitus. Okay, so I think you have understood this type 1 and type 2 diabetes. Proceed.
Yes, sir.
Yes, sir.
Okay, if you have any doubt, you can ask. No? Okay, because this type 1, type 2, these are even there. We will go into the detail in depth. Be there. Why should diabetes be controlled? Now, generally, the patient, even my relative, those who have diabetes or they have been first time diagnosed as diabetes mellitus, they used to ask, and why the diabetes let the blood sugar level may increase, isn't it? What we have said, it is a tip of iceberg, isn't it? The what we see is just an increase in blood glucose level. Now, why to control that increased blood glucose level? The answer will be because it leads to complications. Okay, if we don't control this, control the blood glucose level, bring it to the normal, it leads to complication, and this complication could be seen immediately, that is acute complication, or and it leads to chronic complication also. Okay, what are those acute complications? Is diabetic ketoacidosis. This is one of the important acute complication. And this diabetic ketoacidosis is more common in which type of diabetes mellitus? Yes, anyone?
Type 1.
Type 1.
Yes, very good. In type 1 diabetes mellitus patient who are on insulin, they are more susceptible for diabetic ketoacidosis. And similarly, hyperglycemic hyperosmolar state, HHS, it is also a acute complication where the blood sugar level increases and then the patient may land up to coma. So this is more common in type 2 diabetes of our body undergo the changes. Okay, the lumen become narrower, the atherosclerosis chances of formation of that will be more, the maturation or changes in blood vessels. So blood vessels could be complication into microvascular complication. That means the complication which arise due to changes in blood vessels of microvascular, smaller blood vessels. And so when there is complication, it leads so it damages the retina, so that may lead to blindness. And neuropathy, it means nerve will be damaged. So that is the other. Nephropathy or microvascular complications, and it is seen earlier. So if this diabetes is not controlled and if the blood sugar level is increased for a long period of time, then what will happen? There could be retina damage which lead to blindness, neuropathy, the nerve will be damaged, and the kidney damage. So that is why the patient may land up with kidney failure. Okay, so this is a microvascular complication. Not only that, if this blood sugar level increases for a very long period of time, then it lead to even a damage of macrovascular, that is big blood vessels, and causes complication like coronary acute complications. The diabetes mellitus has to be controlled. That means the blood sugar level in our body, the blood, okay, has to be controlled. Okay, it is metabolic disorder, so metabolism, we have to target to bring the metabolism back to the normal. Okay, so that is why it has to be controlled. Now how we control this diabetes mellitus? Okay, for diabetes mellitus, still now we don't have a cure of diabetes mellitus. Okay, we cannot cure, okay, until unless it is a secondary say diabetes mellitus. If there is some cause for that diabetes mellitus, when you treat it, like you can say type 3, if there is a cause and you remove the cause, then it could be treated. Otherwise, generally for type 1, type 2, it is not curable. And here what we do is we try to make the metabolism back to the normal. Okay, so how do, okay, is one is non-pharmacological measure. Okay, so non-pharmacological measure, we try to bring this back to the normal without drugs. Okay, I have already said, by changing the lifestyle, the diet, exercises, we can bring the we can treat diabetes mellitus, or we can bring that metabolism, okay, abnormality in of the metabolism to the normal, so we can bring back. Okay, so that is one approach which is very, very important in diabetes mellitus. So that is why in diabetes mellitus we generally counsel the patient regarding the drug, regarding the lifestyle modifications and diet. Okay, so this is very, very important. And I think towards the end of the chapter, we will be talking about the therapy of diabetes mellitus, and in that we will try to discuss about the non-pharmacological measures also. Okay, we will talk there. And similarly, we can use drug. When these non-pharmacological measures is not sufficient, then we have to use medicine. Okay, so in medicine there are two types of medicine what we use in diabetes mellitus. One is insulin and insulin analog. Okay, so we will talk what is insulin and insulin analog, or what do we mean by that analog, insulin analog. We will talk about that. So insulin is the control the blood sugar level. Okay, so and we have insulin analogs also. There is insulin, and other is we can use oral anti-diabetic drugs. Okay, here I would like generally if you hear oral hypoglycemic drugs. Oral hypoglycemic drugs. Oral means taken orally. That oral hypoglycemic drug, that terminology is not a very preferred one. Okay, the preferred, okay, is oral anti-diabetic drug. Okay, so please make a habit of using this terminology, oral anti-diabetic drug. Anti-diabetic means the drug which are used for diabetes or to control the diabetes mellitus, and they are given orally, are oral anti-diabetic drug. Okay, got it? Because why we don't prefer that oral hypoglycemic drug? Because all drugs may not cause hypoglycemia. All anti-diabetic, oral anti-diabetic drug may not cause hypoglycemia. So that is why nowadays it is preferred and it is advocated to use the term oral anti-diabetic drug. Okay, so for the therapy of diabetes mellitus, we go with non-pharmacological measures, the diet and the lifestyle modifications, and then we have the drugs we have insulin and oral. The insulin generally till now we have the insulin which are used by injection route or a parenteral route. So that is why they are injectable anti-diabetic drug, the insulin and insulin analog, and we have oral anti-diabetic drug. Okay, so this picture shows the pancreas over here, and this is what secrete the insulin. Insulin is synthesized and secreted by the pancreas. So this is the pancreas. Okay, the figure showing pancreas. Now, what is this pancreas? Pancreas, it is a exocrine gland which secretes enzymes, and it is endocrine also. So it is a gland which have gland. So exocrine gland, it secretes the enzyme and which help in digestion. We are not interested here. We are more interested in the endocrine gland. In endocrine gland, the isolate of Langerhans, which secrete insulin, and this insulin are secreted by beta cell. Okay, so this is what we are more interested in, insulin, which decreases the blood glucose level. Similarly, it also releases somatostatin, amylin, gastrin, pancreatin, polypeptide. So a lot of other endocrine hormones are released, but we are more interested in insulin. So we will be talking about this insulin because diabetes mellitus, it is related with insulin. Now, what is insulin? Okay, before going into the insulin was some of the very important drug. It was discovered in 1921 by Benting and Best. Okay, so it was discovered in 1921, and Benting and McLeod, the discovery of this insulin was so great that the Nobel Prize was awarded in 1923. Okay, the Benting was a teacher and Best was a student who discovered this. But after the discovery, it could not be used clinically. Why? Because it could not be isolated. So in isolation, the McLeod McLeod and his student helped in isolating, extracting that insulin. So that is why Benting and McLeod were given Nobel Prize. But later on, the Benting shared his Nobel Prize with the Best. Similarly, McLeod also shared his Nobel Prize with his student. Okay. And Leonard Thompson, a 14 years old boy, was the first patient to receive insulin. Okay, that is clinically. Okay, now how important the discovery of this insulin was, if you want to know, there is a few paragraph, two paragraph in this book, page number 608, Clinical Pharmacology 10th edition. Here, trial period only. Okay, before this, Leonard Thompson received the insulin. The person, the feeling of that person is there. I think by today evening I will share that page from this book also. If you want, you can just go through. It is like you can say the story. Okay, just hardly 2-3 paragraphs is there, but with that story you come to know how important the insulin was at that time and why the Nobel Prize was given. Okay, now we think, okay, we take insulin as one of the drug, but it was one of the very, very important drug. Okay, so that you can read. So this is a photograph of Benting and Best, okay, where the dog, in dog, the experiment was carried out. And now this is the newspaper cutting where Benting and MacLeod, they were given Nobel Prize, and then Benting shared with Best and MacLeod shared the Nobel Prize with Colin in year 1923. This is the photograph of acid is arranged in two chain. Chain A, which contains 21 amino acid, 51 amino acids are arranged in two chains. Okay, chain A and chain B, 21 amino acid and 30 amino acid. Now these two chain sulfide bond. Okay, and earlier, okay, before 19. 7, the insulin which were extracted from the beef and pork, they were used. Okay, but nowadays we use human insulin. Okay, human insulin means a insulin is that is very similar to human. Okay, and they are produced by recombinant DNA technology. Okay, so before this recombinant DNA technology was there, the insulin which were extracted from pork and beef were used, and this pork insulin were different from human insulin by one amino acid, while beef insulin was different by 3 amino acids. So that is why pork was less antigenic than beef. Beef was more antigenic. So these beef were producing more hypersensitivity reactions. Okay, it is when we were studying this diabetes mellitus insulin in our undergraduate, at that time it was, nowadays even these two insulin, they are not available. Now human insulin is there, so that question may not be very important for you, but sometime in PG questions and even in MCQ it is asked. Okay, so in that case the beef insulin is more antigenic, so it is very easy to remember also. B comes after A, antigenic B. Okay, AB, that means, okay, so pork is less antigenic than beef, but both are antigenic. Is first synthesized as pre-pro-insulin, which has 110 acid, and this is synthesized in rough endoplasmic reticulum as a single chain. Okay, and pre-pro-insulin is converted to pro-insulin. Okay, that is 86 amino acid, and this pro-insulin, it transported to Golgi apparatus, and there it is converted to insulin and C-peptide. Okay, and this insulin along with C-peptide is stored in granules of beta cell. Okay, got it? Have you understood?
Yes, sir.
Hello?
Yes, sir.
Yes, sir.
Okay.
Yes.
So this synthesis, the pre-proinsulin becomes proinsulin, and then this proinsulin is transported to Golgi apparatus where it is converted to insulin and C-peptide. This is stored. So this is shown here in the animated form. Now see, this is a proinsulin, okay, with 86 amino acids, okay. Here it is 65, if you see like this, 65 and then again 21, so 86. Now this proinsulin, and this one is, this is chain A, this one is chain B, which is linked with the two disulfide bond, these two, and one disulfide bond, okay, and this portion is C peptide, okay. So this is arranged in this way, and now insulin is now broken into insulin and C peptide. So insulin is this now double chain, okay, two chain A and chain B, amino or sequence of polypeptide, okay. This is insulin and C peptide, the remaining portion, okay. That is C peptide. This is stored where? In granules of beta cell, okay. So this is how the insulin is produced, okay. Now insulin, how it is measured? We don't measure this insulin in milligrams, okay, rather we measure insulin in insulin is controlled. The secretion of insulin is controlled, okay, or we can say like synthesis, you know, it is stored in granules. Now from granules, how it is released? Now there are three factors that control the human insulin secretion. That is one, blood glucose concentration. The blood glucose is one of the most important factor that control the insulin secretion. It determines how much insulin and when the insulin to be released. When hormonal control and neural control, okay. So blood glucose, this is very important, okay, factor controlling insulin secretion, okay. Concentration, and then the other rest we will talk in next class. Now what happens, this blood glucose, okay, which is there when we take a glucose or carbohydrate, and the glucose level in the blood will increase. This this glucose will enter into the pancreatic beta cell, okay, with the help of transport, which is known as GLUT2, that is glucose transporter. GLU stand for glucose and T for transporter. With the help of glucose transporter, glucose enter into the pancreatic beta cell, where sodium, potassium get in, and most important is it will close, this ATP will close the potassium ion, okay, which is potassium channel, okay. ATP sensitive potassium channel is being closed, and once it is closed, then what happens, the calcium the ion channel will open, and then the calcium will be released from sarcoplasmic reticulum, and this calcium causes myosin actin myosin complex, and that will cause the exocytosis of insulin. So insulin, what happens is glucose enter into the beta cell and converts it into ATP, and this ATP will close the ATP sensitive potassium channel, okay. And this closing will lead to opening of calcium channel, and calcium enters, and these lead to exocytosis of the granules, and release of insulin will be there, Okay, so this beta cell integrate all the input from various metabolite and hormones and neurotransmitters and do the release. The release is facilitated. Okay, so this animated form, to make it more simpler, there is a diagram. This is what I have taken from Katzeng pharmacology. You can consult. So when the blood glucose level in our body increases, this glucose is transported into the beta cell of the pancreas with the help of glucose transporter GLUT, and by metabolism it is converted to ATP, and ATP closes the potassium channel. Okay, when it closes, there will be depolarization. This depolarization causes opening of calcium channel, and calcium enters, and then there will be exocytosis. The insulin will be released from the gland. Insulin is in two phases, phase 1 and phase 2. These two phases will be taught in detail in physiology. So immediately when glucose level increases, the insulin will be released immediately at once in high concentration, and slowly the concentration will decrease, and again in next second phase the insulin will be released slowly and for a long period of time. So insulin, the blood glucose level will cause insulin to be released in two phases. One, immediate sharp increase in insulin or sharp release of insulin, one phase, and next is the slow release of insulin. So this is, you can say, immediate release. This is delayed release, this one. And if we see the, after taking a glucose, the in type 2 diabetes mellitus, there will be absence of this first phase. When you give glucose to type 2 diabetes mellitus, the insulin level in their body will, this is what is type 2 diabetes mellitus patient. And in type 1, these two peak you will not observe. Give the glucose, but there will be no increase in insulin level. Okay, this is the insulin concentration. So in type 2, there is this first phase is missing, only second phase is there. In type 1 diabetes mellitus, no phases, both first and second phase both is missing. Okay, so this is how you can even differentiate the type 1 diabetes mellitus and type 2 diabetes mellitus. Okay, so for today we will stop here. Okay, if you have any questions, you can ask. Yes, any questions? Are you listening to me?
Yes, sir.
Yes, sir.
Yes, sir.
So any questions?
No, sir.
No, sir.
Okay, so I have